Good afternoon, everyone. My name is Devin Anderson, and I am the engagement coordinator here at AAHD. Welcome to our amazing conversation today around disability and intersectionality. This is our second conversation in the Disability and Health webinar series, and we're looking forward to diving into a discussion of disability health and intersectionality today. Stay tuned for 3 more of these conversations in the spring as we continue to explore questions around social determinants of health and inclusive health research. This event is sponsored by the American Association on Health and Disability as part of our Disability Community Engagement Partner Project, or DCEP. This initiative is working to involve the disability community in health research as part of the All of Us research program. All of Us is an initiative to engage 1 million people or more in health research to improve individualized healthcare for all. We will be sharing information about All of Us in the chat throughout the event, and we hope you'll consider signing up to participate in All of Us. You can learn more and register for the program online at joinallofus.org/disability. Some housekeeping for the event. This webinar is being recorded and will be shared publicly after the event. We have closed captioning and ASL interpretation available. Please notify us if you have any other access needs or troubleshooting in the chat. We also want to remind the panelists to speak slowly for our interpreters as well. We hope you'll participate in our evaluation survey, which should pop up in your browser. And we're also going to share that link in the chat for you to let us know your thoughts on the series and if there's any upcoming topics you would like us to cover. With that, I'm going to turn the table over to our moderator, Theo Brady.
Hi. Hopefully everybody can see me okay and hear me okay. My name is Theo Brady. My pronouns are he, him, and his. My visual description, I'm a Black man with a bald head, salt and pepper beard, wearing eyeglasses, sitting in a motorized wheelchair. I am also the executive director of the National Council on Independent Living and a council member of the National Council on Disability. I have lived with a disability since the age of 15 due to breaking my neck while playing high school football. So let me start by thanking all of you all for joining us here and giving, and I want to give a short overview of why we're here and doing this webinar today. Disability is a natural part of the human condition, which occurs across all ages, genders, identities, racial, ethnic, language, and social groups. According to a report from the National Council on Disability, NCD, in 2022, it states, for people across all categories of disabilities, obtaining and maintaining a good health has been elusive for an unwelcoming healthcare system that for decades had failed 26% of the United States population. So much so that people with disabilities utilize the healthcare system for disease management instead of disease prevention. And this is important. They even view the healthcare system as a source of potential harm. Today in the United States, if you are a person with a physical, intellectual, or developmental disability, your life expectancy is less than that of someone without a disability. You are more than 3 times as likely to have arthritis, diabetes, and a heart attack. You are 5 times more likely to report a stroke, chronic obstructive respiratory disease, and depression. You are more likely to be obese. You are significantly more likely to have unmet medical, dental, and prescription needs. If you are a woman with a disability, you are likely to receive poor maternity care, and less likely to have received pap smear or a mammogram. If you're a pregnant woman with a disability, you have a much higher risk for severe pregnancy or birth-related complications, and even times the risk of maternal death. If you are an adult who is deaf or hard of hearing, you are 3 times likely to report fair or poor health as compared to those who do not have hearing impairments. If you are intellectual disability, it is the strongest predictor of COVID-19 infections and the second strongest predictor of COVID-19 death. If you live in a rural area, your disability appears to further worsen barriers to accessing healthcare. These disparities are exacerbated if you are a person with disability and a person of color. So today we have a panel of experts. I'm very excited about the experts we have here today. And we will have an extensive conversation about disability intersectionality when it comes to healthcare. So today we have Kiana Jackson from New Disabled South, Dr. Kara Ayers from the National Center for Disability Equity and Intersectionality, Keith Jones from Soul Touching Experience, and then we have Shane Lamba from the Pride Study. So first we're going to have all the panelists do a brief introduction, and then I will come back to Kiana to get things started, okay? Kiana, can you introduce yourself?
Hi, everyone. My name is Kiana Jackson. Visual description of me. I am a 26-year-old Black woman. I have locks that are kind of pulled asymmetrically to the side. I have on big square glasses. I'm wearing a white and black striped pattern shirt. And my background is a white wall with a sign that says kitchen above my head. I am the Director of Data and Research at New Disabled South, born and raised in Albany, Georgia. So I am a rural Georgian, and really excited to get here to talk about this work. I am a disabled person. And so all of this is really important to me, and all of us, the program is really important to me as well. Thank you for the opportunity to be here and to talk to all of you all today.
Welcome. Dr. Kara, could you introduce yourself?
Yeah, sure. I'm Dr. Kara Ayers. I'll start with a visual description. I'm a white woman with shoulder-length brown hair. I'm wearing a blue and navy striped sweater, seated in a manual wheelchair. And today I have a virtual background that gives me some hope of sun. We don't have that in Cincinnati, Ohio right now. I am an associate professor at Cincinnati Children's Hospital and University of Cincinnati College of Medicine. I bring a number of perspectives to this work as well, including my title as the director of the National Center for Disability Equity and Intersectionality. But even more importantly to me, my lived experience as a disabled woman, as someone who grew up in Appalachia, as a disabled parent, and a number of different identities that I'll share as I chat a little bit more in a few minutes too. So thank you so much. I'm really looking forward to this conversation.
Awesome, awesome. Keith Jones, can you introduce yourself?
Thank you. First of all, I want to thank you all for having me. My name is Keith Jones. I'm an African-American male who is bald-headed, wearing a green t-shirt against a neutral background. I also have glasses on. I am the president and CEO of Soul Touching Experiences. I come to this work honestly being a person with a disability and wanting to not be sick, but as well as talking about how the access points to receiving healthcare, whether you are a male or anybody with a disability, from local, state, and rural and federal policy. So thank you for having me.
Awesome. Shane, please introduce yourself.
Yeah, hi everyone. Good morning or good afternoon. My name is Shane Lamba. My pronouns are he, him. A visual description of me is I'm a 29-year-old Indian American man. I have short styled hair with a mustache today. I'm also wearing light brown glasses with a kind of teal button-down shirt. And my background is blurred and you can kind of see a little bit of my fan in the back. A little bit about myself. I'm a research associate with Stanford University's The Pride Study, which stands for Population Research in Identity and Disparities for Equality. I'm a co-investigator on an ancillary study looking at disability health among the LGBTQ plus population of adults, also known as lesbian, gay, bisexual, transgender, queer, or questioning. I'm very much interested in disability health, and this really stems from my mom's involvement as a special ed teacher, working with her students, as well as seeing how patient and caring and improving the quality of care for those students with their educational needs. So this has really brought me to work in this space. And previously, I was also a researcher at the VA Palo Alto Healthcare System Spinal Cord Injury Center. I'm very excited to be here and also very much elated to be part of this panel with these excellent co-panelists. Thank you.
Awesome. Awesome. Thank you very much. Okay, let's get started. Kiana, you have up to 15 minutes. What do you have to share with us?
Yes, thank you. So today I am really going to be focusing on how all of us can be used to examine some of the barriers facing people who are multiply marginalized. So with my organization, the work that we focus on are disability rights and disability justice, particularly highlighting disability justice as we work through the 10 pillars of disability justice coined by Sin's Invalid. And one of those key initiatives of that is the understanding of the importance of intersectionality. And so today I am going to be talking a little bit about some research that we've done at New Disabled South that highlights how disability and race really intersect in the broader implications of that. One of the first big initiatives that we had that we're also going into a lot of our other states are really wanting to highlight and examine the home and community-based server waiver wait list and recipient list that is present throughout most of the South. So as we got started on this journey, we were hearing in a lot of our communities of people saying, we don't believe that Black people get waivers. We don't believe that people of color have the same opportunity to get waivers. So that was a question that was posed to us by our community, and we took it upon ourselves to go and look for that information and answer those questions. So we published a report, and I'll put it in the chat. We published a report called Uncovering Disparities in Georgia's HCBS Waiver Waitlist. And what we found in this report were significant racial disparities that existed within Georgia's home and community-based server waitlist. For one, we found that there was a 15.28% disparity between the chances that a Black person would come off of the wait list in comparison to a white person. And what that just means is that Black people are less likely to come off of the waiver wait list in the state of Georgia. Okay, so the wait list in Georgia, one question was posed was, what is define the wait list? So in Georgia, you have two wait lists. You have the now wait list, which is the new opportunities waiver, and you have the comp wait list, which is the comprehensive waiver. And so the difference between those basically are the amount of services that you need in order to be in community. So I'm sure most of us know of the Olmstead decision was based in Georgia, and that just says that people with disabilities have the right to be in community. And so those waivers are meant to help people get services to be in community. Well, you have to apply to get on the wait list, and then you have to apply to get on the wait list, be approved to get on the wait list. And then in order to get off the wait list and get services, the state of Georgia has to fund a waiver for you. And by funding that waiver, that comes from the state legislature saying, hey, we're going to give X amount of dollars every year in order to fund however many waivers. Well, in the state of Georgia, we had around 7,200 people that are on the wait list, meaning these are people who qualify for services, but they do not yet have the financial resources to get them. And so the state of Georgia then has to say, we're going to fund X amount of waivers. And up until this year, they only funded 250 a year. But after a lot of work from ourselves and other grassroots organizations, we were able to bump those up for them to annualize 500. And so that's the waiver wait list. But an issue that we were seeing is even once people came off the wait list and they got a recipient and they became a recipient of the waiver, people were having issues with even receiving the waivers because of this low wage that direct service providers have in the state of Georgia. So when we're looking at the wait list, one thing that we saw was that there was a 15.28% disparity between Black and white people who were able to come off the wait list. So then we did an even deeper dive into what are the actual racial compositions of this wait list. And what we found were that there were 28% more Black Georgians awaiting waivers compared to white Georgians. So automatically we're seeing more Black people are just waiting. And what we also saw were they're waiting for a longer period of time. The next thing we wanted to look at is what is the prevalence? What is the distribution of this, right? So we were able to get age data and see distributively, what is this looking like in this racial comparison? So one of the key things we found were that 12.7% of those on the wait list are under 18. And for every demographic, there were a higher number of Black people, a higher percentage of Black people in every age demographic besides those who were over 65 and older. The most significant disparities that we saw were between the age groups of 25 to 34 and 34 to 44. And the disparities between that were, there were 44.5% more Black people awaiting a wait list in the age range of 25 and 34. And there were 67.6% more Black people awaiting a waiver between the ages of 34 and 44 in the state of Georgia. But when we looked at the recipient list, we almost saw the opposite. Looking at the recipient list for those same age ranges, 25 to 34 and 34 to 44, the percentage difference were 13% more white people were receiving the waivers for ages 25 and 34, and 4.5% more white people were receiving the waivers for ages 34 to 44. And full disclosure, the reason why we were only able to do a deep comparative analysis of Black and white is because there was a large chunk of people who fell into the category of unknown or refused race, which kind of made the remaining races that we had, we couldn't really do an accurate depiction of that because it just didn't make up a statistically significant portion of the wait list. But going back to some of the things we saw is that really interesting were for the age range of 18 to 24, there were 40.63 more white recipients than Black recipients. However, that same wait list, that same age range for on the wait list, there was 11.4% more Black people on the wait list. So what we're seeing is that it's not just on the wait list where we're seeing the disparities. These disparities exist on the recipient list as well. And they're almost the polar opposite. Black people are waiting longer in the same age ranges and white people are not. And this is not to say that the state of Georgia is intentionally withholding waivers from Black people. That's not an accusation that we're making, but what we're saying is that the systems that exist in our states, in our government, federally, locally, they inherently breed and inherently cause racial disparities, excuse me. Another thing we wanted to look at is, a lot of times when we think about disability, we think about it in the terms of health, but we wanted to see what are disabled people experiencing in community, especially when it comes to law enforcement and policing, because all of these things are contributors to health, right? And so one thing that we wanted to tackle were, how are disabled people being treated in community, and how does this lead to institutionalization of disabled Black people, Black and brown people? So at New Disabled South, we conducted a multi-state survey. We surveyed around 4,650 people. And of those 4,650 people, over 1,700 were disabled people, and over 1,000 were Black people. And this consisted of 20 questions that focused on the experiences of disabled people within law enforcement and community. And so I'm going to pull out 2 questions that really stuck out to us in the, and we are going to be releasing this report on February 8th. So this will live on our website, but we partner with Data for Progress to do this survey and create this report. And like I said, it is going to be living on our website on February 8th. And so I'll link you to our reports page. But 2 questions that stood out to us were, the first question we asked was, do you agree or disagree that disabled people or people with physical or mental conditions experience discrimination due to their disability when interacting with law enforcement in your community? And across every one of the states that we surveyed, it was Alabama, Louisiana, Georgia, North Carolina, South Carolina, and Tennessee. Across every state, we had an agreement with that statement. And that means that across every state that we interviewed, across every state that we surveyed, everyone agreed that disabled people experience discrimination when they're interacting with law enforcement. But when we look down even more at the racial differences and responses to that, in every one of our states, white individuals who interviewed, they had a net positive agreement, but it was never over 5 percentage points. However, comparatively with Black individuals that we surveyed, there was not any state where the percentage point was less than 28. So even though they all agreed, the level of their agreeability with their statement were extremely different. Black people overwhelmingly feel that disabled Black people are experiencing discrimination when they're interacting with law enforcement. The next question that we pulled out that was really interesting was around the preparedness of law enforcement to engage with disabled populations. And once again, across every one of our states, people disagree with that statement. They don't believe that police officers are prepared, or trained, or equipped to engage with disabled people. And when it comes to mental health crises, wellness checks, these communities do not believe that police officers and law enforcement officials are equipped to dealing with those who are experiencing some mental health crises. And once again, when we looked at those who knew someone who was disabled, who engaged with law enforcement versus those who didn't, even though there was a net disagreement that police officers and law enforcement officers are equipped, those disagreements were vastly different as well. People who know a disabled person who engaged with law enforcement were much more likely to say that law enforcement were not equipped or trained enough to engage with disabled populations. And so those are really important conclusions to have. And this shows up in various ways. When we look at the institutionalization of disabled people, around 66% of people in prisons identify as having some form of disability. And those disparities are even broader when we look at it through race. So when we look at it through race, Black and brown populations, Black and brown disabled people are overrepresented in prisons. And those differences are even greater when you look at disabled women. So for Black and brown disabled women, they are overrepresented in prison populations. And so all of these things, when these are things that we investigate in New Disabled South, what are the intersections? What other factors are coming into play? And this is the work that we're doing. Like I said, we're expanding this research to three more of our states, Texas, South Carolina, and Virginia this year, really focusing on their waivers and waitlist systems. So I hope I didn't go over too much, but I just really wanted to highlight all of that information and really talk about the importance of looking at disability through a lens beyond cure, but looking at it from an intersectional perspective. Thank you so much.
That was awesome. Great information. Thank you so much, Kiana. Okay, Dr. Carroll.
Yeah, thank you so much. That was excellent. I've been excited about the New Disabled South since I heard of your launch. And so it's just wonderful to be able to hear about your latest work and also to get a little bit of a preview of the February report. So thank you. I just shared my screen and I'm hoping folks can see it. So I am going to zoom us out a little bit and perhaps give a broader view of what intersectionality has meant to our work at the National Center for Disability Equity and Intersectionality, and how thinking about what it means has also directed much of our work. So this slide has a photo of me in my wheelchair coming down the hallway of our office, which is within a hospital system. And on the left of this slide is a weaving of different colored, maybe ribbons or even pieces of paper. And so there are just many different ways or approaches to define intersectionality. And one way is to think about this interweaving of identities and social categories. And that's a start. And you hear people also describe it as layering of identities. But we can't stop there. We also have to think about the power structures in our world and how these give us more and less power, and how this can vary based on, where we live in the United States, who we live with. So these inequities can really result in how and whether we can access health resources in our society. And it helps me to think about health, outside the walls of a hospital as well. And Kiana did an excellent job giving us some very specific examples of how health is impacted by interactions with law enforcement. And our center as well has looked at those. We have looked more in depth at in schools at school resource officers or SROs. We've pulled together and looked at the literature that shows that students with disabilities are more likely to be disproportionately harmed and the victims of violence from these school resource officers, that the school resource officers often have little to no training around disability. And maybe even most alarming to us is that we found that even when they have training, we're still seeing these disparities in the research in terms of harm to kids with disabilities, and especially at even higher rates, kids of color with disabilities. And so what we're kind of sounding the alarm bells on related to that finding of looking across the research is this is not a question that we can address, or this is not a problem that we can address by just kind of throwing more training at it. I love education. I love learning. I like to think that we live in a world where harm that happens to people because of who they are is because people just don't know. But that is not true. The data is sounding the alarm for us that there are systemic forces that are perpetuating racism, ableism, sexism. The list goes on. And so we can't just do more training, have more studies without really thinking about the questions that we're answering. And I think of these things too personally, as a parent of children with and without disabilities, as a parent of white children, as well as a child of color. I mentioned that I come from Kentucky. I now live in Ohio, but still the roots in Appalachia are strong in me. And I also recognize that I have privileged identities, including the fact that I was able to obtain a PhD and my role as a researcher. And those privileged identities are a call to action for me to use that power in a way to bring others along with me as well. Our center is something that I'm very proud of because we're a compilation of so many different amazing people and groups. This slide has a look at our mission, and I'll read it for accessibility. The National Center for Disability Equity and Intersectionality aims for greater equity for people with disabilities through disability-led initiatives targeting ableism and additional forms of oppression with an intersectional lens. This slide has a list of our logos that are partners. We work together. So we have ASON, the Autistic Self-Advocacy Network, Georgetown University, the National Center for Cultural Competence, our USED that I mentioned at Cincinnati Children's, Morehouse School of Medicine, and the Maryland Center for Developmental Disabilities at Kennedy Krieger. Since our start, we have talked about what does intersectionality mean to us. And this slide has a little work in progress sign hanging because these are conversations that we continue to have. So one of my favorite articles that kind of captured our thoughts around this as a group, but written by an amazing early career researcher named Amber Davis. Within this article, she notes that intersectionality relates to additive hardships, chronic discrimination, and cumulative trauma. And we can't stop there. Also, it promotes flourishing, resiliency, empowerment, and strengths building. And Amber really taught me that we can't only look at intersectionality as an additive list of hardships or even marginalized identity without also considering the immense strengths that these identities bring to people's lives as well. Also pulling from ASON's equity plan, intersectionality is a term that describes how many identities interact to create unique patterns of oppression. It helped me to think in pictures, and this slide has a picture that helps me to think about the scope of our work and the context and the environment. So this slide shows a garden, probably I imagine in the midst of summer in our area of the country. There's rows of different plants, looks like some cabbage or lettuce, lots of greenery, and also some wildflowers are kind of surrounding the garden. And so we want to think about, what's missing from our garden, who is tending the garden, who is really doing the labor, what unintentional but very real harm is contributing to our shared garden that we all benefit from, who among us is kind of shouldering an unfair burden. So we work hard to compensate participants, ask who's missing. And we work to invite groups that, especially in our case, disability has not been their central focus. So when we built our community of practice, we started actually with groups that didn't have disability in their name. So we work with groups that support people who were previously incarcerated, opportunity youth, the groups that support opportunity youth, which I learned to update my language that at risk wasn't appropriate term. We have groups that represent Asian American adoptees. We have lots of great membership of groups that fight for reproductive justice, climate justice. The list goes on. So we really try to build our garden, plant our seeds with groups that disability wasn't at the center of their work, but groups that did work in an intersectional way and towards equity. And then we kind of, if you picture the wildflowers around the border, then we have added in disability groups that also think about disability in an intersectional way and working towards that disability justice framework that Kiana mentioned as well. And so we're just now reaping kind of the benefits of planting our seeds. I don't think we're quite to this beautiful garden goal yet, but we'll get there. And it also helps to remind me that, so much of health is outside of the hospital walls, like this garden. The way that we conceptualize ableism, racism, and many other forms of oppression is illustrated in this image of a smokestack coming out of what might be a factory. This is a black and white image, brings about kind of feelings of doom and misery, at least for me. And racism and ableism are so embedded in our systems that we often don't realize when we're being taught these messages of non-disabled supremacy, white supremacy. And so we really need to actively work to unlearn it. While we can see with this image the smog, and we can imagine the very literal damage it would do to our health to breathe that in, if we live just a couple of miles from this, it would still be dangerous to our bodies and our minds, but we wouldn't be able to see it, and many people would likely overlook it and ignore it. And that is similar to how we view the oppression that we fight, and we see it as a call to action, not just for ourselves as researchers, but also for healthcare providers. We don't think that you can just kind of stand in the margins or just stand in your clinic office or your operating room as a healthcare provider. And even if, what you do day in and day out is treat patients, quote, equally, that's not enough, because we don't live in a world that is functioning in an equal or an equitable way. So we really need everyone to join in the call towards more equity. So as I wrap up here, I really want to get us thinking about what different kinds of questions researchers can ask to address disability health in an intersectional way. I, for one, am tired of studies comparing autistic preschoolers to their typical peers. Why? An autistic preschooler is never going to be a typical peer. And I understand like the original why, I suppose. I did survive and surpass my statistics classes, and I earned my PhD in a research field. But all of these studies that just compare disabled populations to non-disabled populations don't help move disabled populations in any direction. We're never going to be non-disabled. I don't want to be non-disabled. So why don't we ask questions that are important to our communities? And I'm also tired of the overuse of surrogate reporters. Don't title your study about people with whatever disability it is, when I look further into your study and I realize that you didn't actually ask people with that disability anything. I mean, I've read studies where they've asked parents and teachers and sometimes even strangers about this disability, and they claim to be doing research on and about and for people with this disability without ever asking them. Sometimes it's harder to ask people with disabilities research questions, but your job is not to do the easy work. It's to do what's needed, what's meaningful. And I'm also tired of looking at disability without its context and its environment. So I want to see us move towards a more just model. And if I had to drop a quick book recommendation, it would be from Rua Benjamin. She cautions us as researchers that we don't want to perpetuate what she calls datification of injustice, meaning we just hunt for more and more data. And this is a barrier to acting on what we already know. So we know that disparities exist. Let's not stop there. We need to start building the curb cuts. I really love this last image that I'll show you from Robert Wood Johnson comparing equality and equity. And this shows a curb, first of all, a step that is missing a curb cut, and a person who has a white cane and also a wheelchair are facing this obstacle. The next slide shows a curb cut as well as some audio signals for the walkway. And this, can also be applied in research. We need to expand the way that we think about research so that we're disruptive of what we've done in the past and we can get different results. So thank you so much, and I look forward to the panel discussion.
Okay. Great stuff. Kiana, Dr. Ayers, great stuff. We're already off to a great start here. I'm looking forward to the rest of it. I love what I always say this. Ableism and racism is our greatest challenges. What we have learned, we can unlearn, and education is the key, right? So I can already see that the need for this webinar need to be broadcast widely, greatly. And so I'm looking forward to the other two panelists and what you have to say. So let's bring on the great Keith Jones. Keith.
Thank you. And I want to thank Katrina and Dr. Ayers for going and setting up this discussion in terms to the impact of race, ethnicity, geographical location, and its relationship to how people see their healthcare experience. Also, thank you to Dr. Ayers for laying out the larger view for what it is in terms of intersectionality and how people see it. Again, for myself, my name is Keith Jones, African-American male with a disability from birth. So that being said, being born last century, last millennia, for those of us who remember when TVs used to go off at 2:00 in the morning. That the reason I anchor it in that Gen X part is because the data that we're talking about, the term intersectionality and how disability justice, disability rights, access, DEI, all of these terms in terms of the way communities have started to identify in the way that in terms of intersectionality, in terms of your gender identity, your gender conformity, your gender identity, your socioeconomic status, your migrant status. All of these things are part of what we call human. And so what we've seen in terms of the last 15 years, last 20 years, just in terms of access to services. Prior to 1999, there was a level of healthcare access, whether you were urban, suburban, and or rural. Post 2000, there's been a significant decline in healthcare access in suburban and rural areas, as well as the inner city, with this shifting from, a grand experiment in the late 40s and the 50s and the Eisenhower and the rise of the Medicaid and Medicare model. What we've seen is that data collection only shows us what the social impacts of racism and classism actually do. When we talk about data collection in terms of what are healthcare disparities for Black and Brown individuals in relationship to their white counterparts, there's a reason for that data. When we talk about what is the disparity between healthcare for people with disabilities and people without disabilities, there's a reason for that. And what we as researchers and as activists and as policymakers have yet to do is address that the core of disparity is intentional, racist, classist, systemic outcomes that are desired. You don't have a 40-year gap in healthcare disparities with Black and Brown communities versus their white counterparts without an intentional and or complicit seeking of those outcomes. If you're talking about healthcare disparities for women with disabilities and without, who are Black and Brown, who are giving birth, the rate of death or complicated births is exponential. That is not because people with disabilities do not have the ability to give birth, depending on their human condition. It is a practice and a practicum. What we have never had is a large-scale call for medical schools to not teach ableism. We've never had a large-scale call for policymakers to not embed in terms of human conditions and diagnoses that would exacerbate our barriers to access. So if you are a person of color, we understand environmental factors play a part in that. And when you look at where are our most polluted sites in terms of public transportation, if you are using diesel buses, this is prior to the switching over or to NRG or clean buses, healthcare disparities in terms of respiratory illnesses, asthma, chronic conditions and illnesses were absolutely higher in communities that were closer to those kind of standings than they were if you were out in the suburbs. Those are not by happenstance. When you study the history of how these cities and how our country has come about, why redlining has taken place, medical access, why was there such a large fight in 2007, 2008, and 2009 that the country refused to go to universal health care. And we defaulted to what we now have as the Affordable Care Act, which sprang from work in Massachusetts in the mid and late 90s, which we call Medicare and that's Health for All. Giving you this architecture and this overview, because when we look back into our data and we say, what are the service parameters for young Black people in Georgia? What are the service parameters for young Latinos in Texas? Or if you're a young Indigenous person in Montana? or if you're an Inuit in the upper Arctic region of Alaska. As healthcare providers and as service providers and as policymakers, how have we not discussed how we have written into the way we address these issues biases? Racism and ableism is real. There's a reason Black men have a 10-year shorter lifespan. It's not because we choose to die sooner. Dr. John Rich in 2010 issued a report that showed life expectancy by income and race. And at the time, I was 43. And when he put that chart up, that chart indicated that my life expectancy based upon my age and my income was 5.5 years less than my white male counterpart. So when we talk about data, what is the importance of data? We know racism exists. We know that ableism exists. We understand that there are large swaths in this country that do not have access to healthcare. So when we are collecting data, we are doing this not just to say, see, we're telling you people are dying. We are telling you this so that we can give you policy prescriptions to fix it. So as an advocate, putting on my advocacy hat for a second, one of the things that we do is we go to you and say, please stop being so dysfunctional towards us and do your job. But at the same time, the fact that we have to convince doctors to discuss with us as patients about our healthcare kind of belies the point of you being in healthcare. If I have to convince you that my humanity is worthy of treating, but you are too uncomfortable to treat me because you're ableist or racist, then you are in the wrong profession. But we understand this because the history of studies and data collection in terms of access to service, state delivery of services, those who are on waiting lists, those who are not on waiting lists, those who get 5 services for every 1 service an individual gets, ubiquitously, it is boiling down to race and access to services. This is not hyperbole. We can look at it if you overlay school maps, school funding maps, school attainment, healthcare outcomes, health life expectancy, socioeconomic status, and upward mobility, you will see that it pretty much breaks down upon socioethnic and racial lines. That is by design. This is not hyperbole. When you talk about why do we consistently have a failure of community access points for people with healthcare needs? Why when we talk about elders, we don't talk about aging in place in community supports? What we also understand is that those communities in which these disparities exist are also some of the more inaccessible in terms of mobility. So how does that play out in terms of intersectionality and disability policy? For us to be here to convince the community of healthcare providers to do what they have intentionally signed up to do shows that there is a deeper issue in which people have not come to the forefront and say the reason that we are not going to serve you is because you're Black and queer. The reason we're not going to serve you is because you're brown and non-English speaking. We just don't like y'all. We would rather serve white middle-class kids. That would be a little more honest than saying, well, Blacks tolerate pain better than whites, so we're not going to give you medicine for the injury that you have. If you are nonverbal, you do not have the ability to explain to me what your healthcare situation is. These are real world scenarios in which the data that we have heard about and you will see underscores this. So what is the intersectionality part? Why do I need to convince you that as a human, I come in with all the complexities of my life, and as a provider of medical services, you are supposed to speak to me in order for me to achieve a level of health that is sufficient for my existence? And so when we stand back and we say, what can we do in the future so we never have these discussions again? Real simple. One, make sure that when we are talking about people who are entering in the medical profession, that they are actually entering the medical profession to serve the people who are there. Secondarily, there needs to be a shift away from profitability of healthcare into a community-based health wellness system. Because as long as there's profit in keeping people sick, disabled people will be grist for the mill. Thirdly, and more importantly, states have the ability to not pay providers a disproportionate amount to do services that they refuse to pay the family members for. In the late 2000s, and then I'll conclude, in the early 2010s, we had something called natural services and supports. And there was community-based centered planning and human-centered planning. So, but what does that mean to intersectionality and race? As a father, as a son, as a brother, as a Black man in America, as an advocate, when we talk about intersectionality, it almost gives people the excuse to eliminate our humanity. We are complete and complex individuals, and our intersectionality is the fact that we breathe.
Thank you. Thank you. All of the last three panelists have been very upfront about reality. And like Keith and like the others, one of the most frustrating things for me when I talk to the decision maker and people with power to influence is I'm advocating for things that they should already know. Or for that matter, they already know, but not taking action, not being intentional about making things inclusive and equitable. It's something we got to do. Education is the key, and hopefully you all are being educated on some things that you know or might already know, but not taking action. So thank you. Next up, Shane is going to bring us home with some stuff. And let me remind you, please write your questions down so we can, at the end, we will address some questions. So Shane, take us home.
Sure, thank you. Let me share my screen here and get us started. Great. Can folks see my screen? We're all good here? Perfect. Well, I have been taking notes from the previous three co-panelists, and I feel like there's a lot of intersecting concepts and topics that we can kind of discuss in my presentation for today. But here today, I'm, again, just to reintroduce myself, I'm a research associate with the Stanford University's Pride Study. My pronouns are he, him, and I'm really excited today to share some information which I think will help us frame things in a different perspective, specifically looking at like sexual orientation as well as gender identity. But I'm going to be speaking a little bit about my research on sexual and gender minority people living with a disability, specifically talking about concepts related to healthcare access as well as unmet needs, which I think really ties well into a lot of the conversations that Keith had just mentioned previously, as well as Kiana in terms of community and Dr. Ayers in terms of trying to understand people's intersecting identities. So with that, I'm going to shift our focus here to just briefly touch base on some background information for folks, which I'm not surprised, which is probably not surprising to folks here, as many people are probably very much interested in the disability community, as well as probably know a lot already about it. But just to touch base and frame our perspective, as Theo had mentioned early on in the opening of the presentation, about 26% of the US population live with a disability. So it's really important for us, again, to kind of reframe ourselves to understand like the true population prevalence. We also know that people with disabilities are 2 to 3 times more likely to have unmet healthcare needs and are less likely to often receive adequate medications. And about 1/3 of those individuals actually do not have access to a regular healthcare provider. So really echoing a lot of the concepts that have been previously talked about, noting that these are areas of intervention potentially for us to think about programmatically, but also from the policy standpoint. And a lot of the barriers to care when it comes to not being able to receive care and such have really been echoed in these top three categories: affordability of care, transportation issues, as well as insurance coverage. And I really like what Keith had mentioned earlier on, is that, we do not have like a socialized healthcare system here in the United States. So insurance coverage issues and affordability of care seem to be kind of actionable steps to help bridge the gap for people living with a disability and across the United States in general. And with that, I actually want us to also consider some specific SGM, or sexual and gender minority disability disparities. For those who are not aware, but SGM people with disabilities are also known as LGBTQ+, experience heterosexism and ableist microaggressions that often affect mental health conditions such as depression. Feelings of isolationism, social disengagement, and loneliness can often be the factors that affect individuals with respect to their mental health. Eliason and colleagues actually found that when looking at women specifically within the SGM community who live with a disability, they actually faced higher rates of discrimination, post-traumatic stress disorder, as well as other anxiety disorders. Sexual and gender minority people with disabilities also expressed poorer health due to multiple barriers of physical wellness, emotional health, functionality, as well as social engagement. And I think this really can echo a lot of, again, the conversations we've had previously about social determinants of health, as well as those upstream factors that health is not in a vacuum. It doesn't occur in the medical center. It actually occurs around us in our ecosystem, in our communities that we live in. And I really like this last bullet point because I think it's going to steer our conversation for the next couple of slides that I have. But overall, SGM people with disabilities are more likely to delay care because their practitioners are not really aware of their multiple identities. Often people have reported that there's less comfort with their providers in disclosing either their sexual orientation, their gender identity, or even other aspects of their identity. And they also have reported that there's a lot of cultural, almost to say, incompetency with respect to working with the disability population, but also recognizing the unique needs that sexual minority people have, as well as gender minority individuals. So with that, I actually want to share some key results from a recent study that we published in the American Journal of Public Health that specifically looked at barriers to care. And I'm just going to share a few tables, or pretty much one big table that I think has a lot to say about our topic on healthcare needs, as well as understanding the policy and programmatic implications. In this table, I've highlighted with a purple circle some of these odds ratios, or essentially associations with how people with disabilities within our cohort experience certain healthcare barriers. So as you can see here, and on the right-hand bullet point, which I'll read out here, SGM people with disabilities were actually 1.5 times more likely to have a primary care provider. And this was actually very surprising and interesting because it allows us to understand that people with disabilities in our cohort specifically had a primary care provider. But then when we look at insurance coverage or insurance rates, they were actually 1.25 times more likely to be uninsured in the past 12 months. And I say this is interesting because often we think about having a primary care provider as like a proxy to having positive healthcare interactions within your ecosystem, but it seemed to be almost the opposite in our study cohort, where people had a primary care provider, but they were actually more likely to be uninsured. And jumping into kind of more of the meat of this table, we also noted that individuals, SGM people with disabilities, were also more likely to delay care, and as well as be unable to obtain care. So this also throws kind of some questions in the pot of, well, they had a primary care provider, but they're delaying care, but they're also unable to obtain care. And we asked these participants, what were the reasons for delaying care? And the top 3 issues were affordability, insurance coverage, and appointment availability, which was also pretty much documented in previous research in the general disability population, noting that there might be some shared experiences for people who are LGBTQ+ and also live with a disability. But when we look at, oops, doesn't want to move forward. There we go. When we look at, further understanding what might be unique to the LGBTQ plus population, we also reported that SGM people with disabilities were about 3 times more likely to actually delay care because of disrespect or mistreatment. And we know in previous research that SGM people are disproportionately affected by discrimination, bias, when seeking healthcare services, but those also extend outwardly into their community, into their everyday life, working in their workplace, in their with their friends, with their family. So those are some considerations to think about when we consider policy implications, because we also want to not only always focus on the healthcare system, but also about the surrounding factors and the surrounding structures that are around us and in our everyday life. There also were comments about the fears of discrimination because of their multiple intersecting identities. So people do have some sort of apprehension to share their identities. And I think what's really important for us to understand, and I think we can probably all agree, is education is a very pivotal part of changing the landscape of how we interact with one another and how we unlearn previous biases and other ideologies. But I think what we want to really focus on is making good quality and patient-centered, as well as community-centered tools to really improve the quality of care that make sure that people living in the disability community who are also LGBTQ plus can navigate their landscape and their healthcare landscape. Secondly, I want to share that we also want to, like Keith had mentioned, figure out what we can do from a policy standpoint that addresses these barriers of affordability, appointment availability, that is really precluding people from getting the services that they need. I think of those things as really, honestly, easy fixes, but obviously have a convoluted and complex structure because it is a government process. But I think having research like this, having conversations like this with expert panelists, and as well as audience members who care very deeply about these issues, can really push our understanding and our advocacy in the right direction. And I know I have about just a minute left here, but in conclusion, I want to mention that SGM people with disabilities, overall have experienced significant healthcare access barriers. And these rates changed based on different disability types in relation to SGM people with no disability. Our study also confirms a lot of what is out there in research in terms of cost, insurance coverage, as well as appointment availability. And I just want to lastly echo that future research should really investigate the further step. And I think this is pointing almost towards what Dr. Ayers' comment about understanding what's going on in the group itself, and not really comparing them to people who are not living with a disability, but in the LGBTQ community, understanding are gay individuals, lesbian individuals, bisexual individuals, or queer people facing different issues and different struggles in accessing healthcare. So with that, I will just say thank you so much for this opportunity, and I am really looking forward to questions, comments, and our discussion.
Thank you, sir. This has been a great group of experts. So I want the audience to hang with us a little bit longer. I believe it, Nuri will be stepping in and bringing in some questions from the audience. So take it, would you please?
Thank you so much, Theo, and thank you everyone for this amazing discussion. I know we had a lot of questions that were already answered by myself, Michelle, Devin, and other panelists, so thank you for that. I won't go through those just for the interest of time. They're very information-packed. Again, we will be sharing all of that information after the fact via email, and this webinar will be available on our social media, so people will be able to see that. And again, apologies for the cart captioning and whatnot. Michelle Sales has dropped in the chat. If you want to email us on accessibility issues, we're open to that. So in terms of the Q&A, we have 6 questions. I'll kind of summarize them a little bit in the interest of time. So the first question is from Lily Greeman. Apologies if I'm pronouncing any names incorrectly. The first question is for any and all panelists. What are some strategies that researchers and advocates can work towards in measuring system-level problems? And then just a follow-up to that, thinking how do we illustrate and communicate to others how these systemic barriers function?
Any panelists want to tackle that one?
Oh, joy. I'll let Dr. Ayers go first. I'll just wait.
Oh gosh. This is such a critical question. And I know Lily does really important work too in working towards data equity. So I think, starting from the place of we need intersectional research. For too long, we've only looked at kind of people as like slices of pie, and we haven't looked at people as whole beings. And I hear that people say, well, that's harder. Well, yeah, but we got to do hard things to get the important answers. So I see that as critical. We need more longitudinal studies to follow people over time. I'm really interested in, I cited earlier Rua Benjamin's work. She mentions, and others have done a lot of important work around weathering and racism, how the impacts of racism literally harm people's biological beings over time. And so if we broaden that lens as well, what might we find if we looked into intersecting experiences of prejudice and discrimination, and what that does to a person over time and their health? And I think lastly, we just need to break out of this model of medicalization of disability, where we see disability and poor health as the same. And even within our disability community, sometimes you hear this internalized ableism where people assume and presume that their health will be bad because they are disabled. And that doesn't have to be the case. Symptoms are not within or at the fault of an individual. They're the result of the environment and the literal air that we breathe, but also the treatment that we receive because of who we are. So I think, in summary, changing the way that we answer questions with research is one important step towards this answer. Now I'll pass it to Keith because I know you have something good to add.
Curses and drag. No, thank you. I think one of the things as researchers, when you talk about it, is, and I think as you just said, Dr., how are we designing our surveys? Kiana, I think when you did New Disabled South, and even with the SGA survey, one of the things we talk about here is, researcher bias, right? How can we get unbiased research when the researchers who are predominantly studying the communities are not from those communities? How can we get, for those who want to believe from their eyes, the IRB system, which makes me crazy. How do we get, researchers to understand that if what is the cultural competency framing of our questionnaires, if they may pass the internal review board, but if you get into a migrant community that has, ESL as a second language, and then you're compounding that with, a disability and lack of trust coming from their cultural background, what we are not talking about is the lack of trust in institutions, because we have been studied to death. We have been researched to death. We have been surveyed to death. And how do we get, and for researchers to say, well, how can we be better? It's kind of ironic considering that you're supposed to be brilliant. So, right, if you're brilliant, then you should be self-aware first of what kind of bias am I bringing to the topic that I'm studying? Do I have a bias? And be real with that. And in my bias, am I defaulting to typical research tropes, the low-hanging fruit? When somebody says I can't study the whole individual, well, you can't study any individual because there are no pieces of people walking around here. There are entire humans that have entire identities, and their gender, their health status, their socioeconomic status are mosaics. So I like to say that we are not segments, we are an intricate mosaic. And I think that we have better research design, more engagement from communities while designing the research, that we'll be able to get to the issues quicker.
Yeah. Just to add to that, I've been studied to death, right? I don't want to die 9 years earlier than my white male counterpart, right? Those are real things, right? And so I don't want to die because of someone biases and an opinion of me based on the color of my skin and my condition in which I live. So eventually, enough is enough. And I think we got to challenge people to take action. But go ahead. Next question.
Okay, wonderful. I was just typing all of that just to reply. So thank you for all of that. So I just posted that on there. The next question is from Jesse Zhang. The question here is, how can you reconcile real tensions so that the deaf and disabled people can get the care and support they need? The background to that was just a lot of people might hesitate to participate in these studies due to medical racism and other factors. So again, how do you reconcile those tensions? And they're specifically referring to the deaf population and then people with disabilities generally.
Anyone want to take a shot at it?
I can try. I'll say that one of the key ways to reconcile these are to, one, validate those tensions and participate in these studies. Speaking in the term of like intersectionality and talking about being researched to death, going back to what Keith and Theo kind of touched on, is you have Black people who are hesitant because of things like the Tuskegee syphilis study, right? You have disabled people who have been historically like abused in research. And so you couple all of that together, and then as researchers, we ask, well, we don't know how to reach these populations. And as a young Black person with a disability who's also a researcher, I can say it's because when you are inviting people into your research and everyone around you is able-bodied, temporarily able-bodied, by the way, because at some point we will all have a disability, but everyone around you is temporarily able, right? Everyone around you is white. No one around you has your background, your experiences. Most of these people are Ivy League educated. And then it's this air in research of, you don't really know what's wrong with you, and I'm here to figure that out, right? And so I think that we reconcile those things by acknowledging the grievances of these communities and working, once again, going back to what Theo and Keith said, working within those communities to fix to acknowledge our biases and change the way we do research, change the way we work with certain communities, and understand that cross-cultural research, cross-cultural training has to be done, and that is not always incubated in a lab at a university, right? So like, how are you as a researcher getting out into your community? How are we as researchers engaging with deaf people? Are we only doing this by the deaf people and the disabled people that we invite to the lab that we're running on our college campus? Or are we going where deaf and disabled people are and wanting to gain the trust of this community, listening to them, and then incorporating what they need into our research? And that's the only way those tensions are ever going to be mitigated in the field.
Yes, ma'am. And we got to challenge people thinking, right? We got to get out of the shadows, right? People with multiple identities and intersecting marginalized races and economic status. We got to come out of the shadows and challenge people thinking. And I know sometimes we believe that we are tired of fighting, but you got to fight, right? And you got to share your stories, and people in power and decision-making position must hear you. And I know it's often difficult sometimes because you don't think you have a voice, but you do. And so come on and carry on these conversations, but more than that, take action, develop allyships with different organizations who do have the power, and let's speak in unity. Next question, please.
Okay, so the next question is Tiana Brown. So I think this is more so of a comment. Working with individuals with disability each day in California. It's the same issues here. It's so sad to hear as a Black woman. Thank you for the info. And then the next question actually is from an anonymous attendee. So do any of the panelists know of any good and effective training programs for medical providers to educate and sensitize them about disability and being a good medical provider to people with disabilities?
I can tap in on that one. I'm a member of the National Council on Disability, and if you go to ncd.gov, you'll see some reports. And one of those healthcare reports in regard to equality and equity, moving toward a more healthcare and equity, you will see that one of our recommendations that is we got to make it mandatory for medical directors and medical schools to receive cultural diversity training, right? And they got to go through it because every one of them have these biases, and every one of them have racism. Every one of them have these ableist ideas about people with disabilities. And if they don't go through that training, and trust me on this, what they have, it took a long time to learn this stuff. It is going to take a minute to unlearn it, but it got to start somewhere. And one of the things that we are pushing this, the Congress and is to, and as well as we have meetings with medical directors all across the country to make cultural diversity training mandatory. And so we're already working on it, but we need grassroots people to talk to Congress as well to make this a reality. Anybody else?
Yeah, I'm excited about the work of the NCD and others are doing. And so once we get that training happening, we also need to make sure that the particular training that we're doing works. Because as I mentioned earlier, training for training's sake without the outcomes that we want, is not going to move us forward. And some of the most shocking research to me shows that medical students are leaving medical school more ableist than they were when they started. So we are harming people. We are exactly what you said, Theo. We are teaching them information along with everything they do need to be a doctor. We're teaching them information that we don't want them to take away. So we really got to dig out, how and why are we doing that? And in addition to the additional information, we got to figure out what should they not be and how should they not be being taught to treat people with disabilities.
Get rid of that thinking. Yes. Keith?
Yeah, just real quick. I think one of the things that, as researchers and what we can do, just low-hanging fruit one, is go back to our alma maters and be like, we can't call ourselves institutions of higher education if we are consistently using those same patterns and practices that belie our intelligence. We can't call ourselves a world-class medical school, and then we are sending kids or sending people into Syria, into hospitals, more ableist. We can't talk about being intelligent and brilliant and say we are able to perform neurosurgery, but I'm not able to be not racist. Those two things are conflicted. When people say we have brilliant surgeons, but I'm a masochist and a misogynist, am I brilliant? No, you're skillful. There's a distinction. So when we talk about research and how do we use the research to move schools, even with NCD, maybe that's one of those things that with the policy you say, for those who are receiving Medicaid and Medicare dollars or CMS grant funds, or you're applying for waivers, here's what's going to happen. Your school system from soup to nuts, your doctors and your practice are going to have to meet certain criteria, and we'll know whether or not you're smart enough not to be racist, because Black people will be less sick. Disabled people will be less marginalized. That doesn't mean that you have to, you don't have to like me to do your job. But if you're in a profession like teaching, like healthcare, where you leave fingerprints on forever, it is incumbent upon us and that institution and them to understand that and to be able to bifurcate their racism and their ableism from their skill set. And if you can't do it, start an OnlyFans and go somewhere else.
Amen. Shane, you have anything to add to that?
Yeah, I was just going to say, I think with training and respect to like education programs, The Human Rights Campaign, as well as the Fenway Center, focus a lot of their research, their training and education modules for the LGBTQ population. So if folks are interested in looking at those education trainings and modules, a lot of healthcare centers participate in the Healthcare Equality Index, which is championed by the Human Rights Campaign, essentially tracks and promotes training of LGBTQ health related topics for their staff and employees. So that would be a really good opportunity for folks if they're interested in looking at that information. I know they may not have a specific disability like module, but I think the conversation of identity and intersectionality of sexual minority and gender minority individuals is really important to translate over generally. So I just wanted to share those resources. I can drop the links also in the chat.
Yes, please do. Please do. Is it anybody, decision makers behind the scene, any additional stuff that we need to share or any finalized questions? Or should we?
Are you referring to in the Q&A, Theo? Or
Yeah. Any more additional questions or instructions before we end it?
we do have, I would say, just one last question. There are more comments, and I think that, there are two questions, and I'll just make them quick. One of them is that they had mentioned that the U.S. is rapidly becoming a more elderly society. So I think what was mentioned was 26% of it's just saying what portion of the 26% of United States citizens disabled are elderly.
I don't know if I have the numbers on that. We can definitely research that and get back to you. But I think someone said this earlier. We are all aging into limitations, right? I think it was Kiana. We're all aging into disabilities. And so let's be realistic about this matter, right? Let's start fighting to ensure equitable healthcare right now before you actually need it. Right? It don't take a brain surgery. I'm not an eloquent person, and I don't have all these eloquent words to tell people to take action and do these things. But so it's common sense, most of it, right? We got a population here that is not being seen or not being addressed. People with all types of different disabilities, identities, and social economic status are not getting adequate health care, not being recognized. It don't take a brain surgery to say something different got to be done. And so I think that's where we're at. And so I don't have those numbers, but again, we've been numbered and studied to death, right? Anything else, Nuri?
No, I think that's it. Just in the interest of time, those are all the questions. And
Awesome. So let me say this in regard to bringing this to a closure, right? I hope we have provided some greater knowledge of the disparities within the healthcare system as it relates to people with disabilities and intersectionality. And there is power through knowledge. Let me say that again. There is power through knowledge. Educating yourself, becoming aware of the disparities and the treatment of people with all types of disabilities and marginalized identities. So the question becomes, what are you going to do with your new superpower? What are you going to do with the information you have? And I think one of the things that we need to do is to continue to have this conversation. But more so, and so there's tons of information that's going to be available. We have provided you with that information, and we're going to continue to work. So the question is are you going to join us? Right? I hope you do. Thank you all for being a part of this. And so with that being said, we're going to end this and say, be well.
We scoot off. I want to say another round of thank yous to our amazing panelists today. We could not have done this without you. So applause all the way around for you guys, for Theo Brady, amazing work as our moderator as well. In the chat, you will see that I've posted quite a few times. We do have a virtual office hour drop-in session that you can register for. It's in the chat. We can also email it out to everybody, but that's going to be Friday on Zoom at 1 p.m. Eastern time. So you can feel free to pop in, continue the conversation. If you have further questions, we would love to discuss that with you as well. And please, if you have any questions about the All of Us research program, how you can be involved, what you can do to help push this, push these narratives further and increase these conversations and the exposure, we would love to have you on board with the All of Us program to help us get greater personalized medicine out to those who need it most. And I think it's all of us. So again, thank you again so much. The information will be sent out. We will be working on the captions for the presentation, so that will be distributed publicly as well. And if you have any further questions, our contact information is also in the chat. Thank you again, everyone. Have a wonderful rest of your day.
Take care.
Bye now.
Bye-bye.